So let me welcome everyone who's here. Not too many. I trust there are some more online. So we are on virtual, and here this is a speaker program of the National Capital Area Chapter of the Depression and Bipolar Support Alliance, and we're very pleased to once again have a hybrid program, speaker in person and on Zoom, and we have lots of people now affiliated with our chapter from out of town. I'll mention our website, DBSA-NCA.org, and you can check all about our various support groups that meet several nights. We have, I want to say, 7 or 8 virtual groups and 2 meeting in person, one in DC, one in Silver Spring. And it's my pleasure and honor tonight to welcome back Dr. Carlos Zarate, who's been in times past, pre-COVID, a frequent speaker. And we're glad that he is able to make it and join us tonight and tell us what's new in research and treatment. Let me try very briefly say a few things about Dr. Zarate. He's an NIH distinguished investigator and chief of the experimental and therapeutics branch and of the section on neurobiology and treatment of mood disorders, Division of Intramural Research of NIMH. He's also clinical professor of psychiatry and behavioral sciences here at the George Washington University. Dr. Zarate has received many distinguished scientific awards, so I will not attempt to go through all of them. What are the major ones? He's a member of the board of directors of the American Society of Clinical Psychopharmacology, member of the Society of Biological Psychiatry and Neurosciences. In 2020, he was elected to the National Academy of Medicine. In 2023, he received the NIMH Director of Outstanding Mentor Award, NIDA's Directors Award, and was selected to deliver the 16th annual Philip Chang Distinguished Lecture on Innovation and Technology. His research focused on pathophysiology and development of novel therapeutics for treatment-resistant mood disorders and suicide, the study of biomarkers and neural correlates. Let me mention one other award. We're part of National DBSA, the Depression and Bipolar Support Alliance. It gives the Gerald L. Thurman Award. It's the highest honor the DBSA gives members of the scientific community to recognize researchers whose work advances on the causes, diagnosis, and treatment of depression and bipolar disorder. And a year or two ago, whenever it was, one of the recipients, Dr. Carlos Zarate, got the Senior Investigator Award, noting his position. Long-standing research program for over 20 years has focused on developing novel therapeutics for adults with mood disorders. So we are very pleased and honored to welcome back and hear Dr. Carlos Zarate.
Thank you so much. Right, delighted to be here. And what I thought of doing today is talking a little bit about novel treatments, neurobiology. And I have 2 presentations. I'm not sure I'll have time for the second one, but it talks a little bit more about our research program and some opportunities. And so if we can get this working, this is the title, Advances in Neurobiology and Developing Novel Treatments. Okay, see if it does. Okay, so this is to start with the basics about mood disorders. I'm going to talk about major depression and bipolar disorder. And for a long time, it has been considered or viewed as a problem mainly of mood. We know it's much more than that. In fact, it's a disturbance of behavior, activity levels, and some actually think that it's more activity levels than mood sometimes, where you have too much activity or you don't have enough activity. Changes in circadian rhythms, are a big problem as well. But it's associated with significant impairment in ability to function, and quality of life. And so towards the left, I don't think the pointer works here, but you see that there are problems with negative mood, what we refer in behavior, where you have anxiety, depression, irritability, hostility, and sometimes violence and suicidal thinking. You also have, in some individuals, some of our patients have psychotic symptoms, impaired reality testing, such as hallucinations or delusions. Some of our patients feel extremely irritable and sensitive to noise and sound. You have cognitive symptoms and racing thoughts, distractibility. You have poor insight, disorganization. Sometimes you have difficulty paying attention. And then you have the flip opposite, which is the manic mood and behavior, euphoria, grandiosity. One is impulsive. You have excessive sex drive and decreased need to sleep. It's not the same as inability to sleep, which goes with depression. You have decreased need to sleep. Now, this is very in categories, and what the reality is that people have sometimes a mixture of the symptoms. Not only you can have manic symptoms and depressive symptoms at the same time, but it can be of different degrees. And so a lot of times we focus, is my mood down? We give an antidepressant. Is my mood up? We give an antipsychotic or mood stabilizer. We know it's much more complex than that, often requiring combinations of medication. And so some of you may have seen this. This is in Kraplin's classic textbook, where one individual, one of the patients, was sitting down, staring into the distance, and had significant depression, what we call stupor sometimes. Mania was the opposite, and you can see excessive clothing and dressing, but this is the same individual. This is the same individual during the depressive or the manic states. And some of you might be very familiar. If you know someone or you experience bipolar disorder, that happens. And for the most part, it happens in episodes, but it can happen very rapidly within hours or days at a time. Okay. Now, this is what I mentioned, that when this is study done at NIMH by Kathleen Merrick-Angus, perhaps a speaker you can have at some time. And she has looked at biobehavioral domains where what I just mentioned is one aspect of bipolar disorder, but you can see disturbances in rhythms, activity, daily rhythms, and sleep. You can have problems with reactivity, not only being irritable at noise and sounds, but you can have changes in your heart rate variability, that's what referred to, autonomic reactivity, and startle. And this seems to be different in people with depression versus bipolar disorder. And it's a way of better understanding the causes of bipolar disorder. Towards the left, you see changes in brain morphology. When we do brain imaging, you might see differences in white matter in the brains of individuals when you do MRI, hyperintensities, and changes in brain volume. For example, hippocampus might change in people with depression. The hippocampus is involved in memory and spatial orientation. Towards the bottom right, we see changes in perception, olfaction, and people can actually, you can begin to see minor differences in smells that might be very important to understanding bipolar disorder. I thought I heard a dog. And then in the bottom, you hear temperaments. You see differences in affectivity. That's the characteristics, long-standing characteristics or traits of an individual over life, irrespective if you have bipolar disorder. And then in the middle, you see neurocognitive function, that disturbances in attention, concentration, memory that can occur. Okay. Now, we tend to see that bipolar disorder is referred commonly as a brain disorder, but we know it's much more than that. And actually, it's associated with this medical illness, systemic medical illness. So many of the organ systems are infected in our patients with depression and bipolar disorder. So we see towards the left, higher rates of thyroid disease. You may know, in fact, that's a common question I ask my patients. Does anybody in your family, besides having bipolar disorder, use lithium or suicide attempts, or ever been hospitalized, do they have thyroid problems? Postpartum depression is also associated in family members with bipolar disorder. We also see higher rates of migraines. gastrointestinal problems, and higher rates of diabetes. If I have time, I can show you a little bit more detail of problems with inflammation, immunological immune disturbances that we find in our patients. Towards the right, you see that there are greater changes in heart rate variability. And in fact, if someone has had a myocardial infarction, there's a 3 times greater rate of having depression. So you can see that this is not just the brain, but many organ systems are affected. Towards the bottom right, we see, looking at the bone, there's greater rates of osteopenia and osteoporosis, both in men and women who suffer from depression. So it's important that not only you treat your mood symptoms, but you pay attention to the rest of the body, and that your psychiatrist or therapist interact with other medical health professionals. Okay, this is something that I'm not going to get much into, but this was the DSM-5, which we are now, and it's being revised on how the emphasis here was to add, to be an emphasis on changes in activity levels. It was mainly focused on mood. This is to show that in one of the studies of the STEP-AD, which is an older study that was a multi-site study looking at the different types of episodes, how criteria would change with if you had one of our patients, you use DSM-4 versus DSM-5, you would see that the rates of bipolar disorder would change. And the goal of modern criteria was to try to pick up those who had what we called pseudo-unipolar depression, or individuals who had depression but did not have yet hypomania or mania. Because often what you see in the course of someone with bipolar disorder is it precedes the depression, precedes the mania or hypomania by 7 to 8 years. And in fact, clinicians may start an antidepressant where you might be causing more trouble by cycle acceleration or a switching. So there are clues to suggest that that individual who has depression, what we call a pseudo bipolar depression, has which some of these clues include slowing down psychomotor retardation, early onset of depression, such as bipolar depression, family history of bipolar disorder, or high density of family members with a mood disorder, suggest could be bipolar disorder. So those are important factors. And so when we were creating DSM-5 or revising the criteria, it was important for us to try to pick up that. Now, unfortunately, we have no diagnostic test for bipolar disorder. We have the clinical interview. And so it's very important that with one of your patients who's had depression, has not had hypomania, to really spend time speaking with family members and friends to see if there might have been hypomania or mania in the past. Okay, this is to show in one of, you may have heard about this already, but this is what we call the DSM is Diagnostic Statistical Manual in RDoC or Research Domain Criteria. So what we found with the DSM, and it's a textbook that our clinicians use very commonly, is that if we have somebody in front of us who has depression or bipolar disorder, we can pretty much agree that this is depression or bipolar disorder if you follow a criteria. The problem is that after many years, we started with DSM-1, 2, 3, and 4, and now 5, is it wasn't really leading to new medications. So if you look at the symptoms, for example, of someone who has depression, there are literally hundreds of ways of meeting criteria for a major depressive episode. Hundreds of different ways. So how we're going to find the causes, the genetics and the imaging and the circuits involved by using DSM, because it does not map onto neurobiology. And so what was suggested is, you can look at the Venn diagrams in the middle, it's not exact, but the problem is if you look in the middle is MDD, major depressive disorder. But if you're doing the genetics of those individuals, are you really deciphering what is the genetics or the pathophysiology of major depression or is it that of substance abuse or panic disorder or something else that overlaps with that? And so what was proposed is to deconstruct this into more quote unquote simpler elements, dimensions. And one example is anhedonia or lack of pleasure. So we know that it occurs in people with depression. It's one of the two key criteria for making criteria for major depressive episodes. But you can find anhedonia in obsessive compulsive disorder. You can find decreased pleasure in even in healthy individuals. And you can find in psychosis or schizophrenia, it's referred sometimes as negative symptoms. Some would call it anhedonia. These are dimensional constructs. And so what was proposed is to look at those elements I'm talking strictly at the point of research. You could do the same with activity levels. We talked about how people have low activity levels or extremely high. And to better understand that, we may be able to have clues what causes these constructs, these disorders, and eventually new medicines. And so the strategy here with RDoC is you fill those gaps in knowledge, because we have many gaps in knowledge. And at some level, we get information about the environment, community, family, friends. Then you get information on the behavior, then you get information on brain circuits, and then cells and molecules, and then eventually genetics. And as you start filling these different gaps of knowledge, you might be able to come up with better treatments. And so that was the suggestion. So here towards the bottom left, it's not exactly the same figure, but what would happen is that if somebody had depression, we'll give an antidepressant or a mood stabilizer. Here, the goal is if we can find something closer to the genes, such as brain circuits, that's closer than symptoms, and we already talked about symptoms are different from one individual to another, then you link the changes in brain circuits. For example, ventral tegmental areas is the reward center in the brain. And you might find that anhedonia or lack of pleasure is diminished reward and pleasure. And so then you can say this individual who has this change might respond better to this type of medication. And so that is the hope for the future, trying to link biology with the treatment so we can personalize treatment. Okay. So this is kind of one example, and it's a bit of complex map, but we can use brain imaging or resting state, meaning you just lie in the scanner, you have your eyes closed for 5 to 8 minutes, and you have different circuits that turn on and off, that connect, some turn on, some turn off, and they're connected across different parts of the brain. And you can measure this. And this would be different from individual to individual. And some of these might give clues. What we do know, for example, there's one network, default mode network, for example, that is not working right in people with depression. And there's what we call the central executive network that controls your ability to abstract and to think. And then there's the salience. The salience is the ability to filter stimuli, and it's the switch between the default mode network and the central executive network. It doesn't work well. So what we're trying to do in research and others is trying to make sure it works well or decrease the default mode network activity. So beyond treating symptoms, we are looking in others to regulate these networks across the brain. Okay. Now, this is an example of the course of illness, bipolar disorder. For most of the time, it's important to keep in mind, most individuals with mood disorders have another psychiatric disorder and likely another medical condition that's referred to as comorbidity. And that will affect the outcome. So if you're a clinician or you don't, it's important to look for that. And it's not only that you have a disorder, but you can have symptoms not meeting criteria for disorder. So for example, what do I mean by that? You might not have full obsessive compulsive disorder, but you might have symptoms or traits. And it's very important that that get treated because that could affect your outcome. Or you might have subsyndromal panic attacks. Not enough to meet criteria. No, you don't have enough criteria in DSM to meet panic disorder. That doesn't mean you shouldn't receive some type of treatment. So it's important to look for those. But going to the course of illness, if you can see that line unfortunately, the pointer doesn't work, but you can see there's a blue box, and the line represents life of an individual. And the first blue box is a major depressive episode. And what you can see, it's not for everybody, is that, but as time goes by over life, you have more blue boxes. And the time between the blue boxes, that yellow line is the good times, the euthymic periods. You can see they become shorter and shorter and shorter. It is not unusual for someone with bipolar disorder to have more longer depressions as life goes on, and they're more severe and less like they respond to medications. And so you can also see between the first blue box and the green box above the line, that's the hypomania. We already talked about 6 to 8 years might go by, or you might have visited 3.3 different clinicians until they make the right diagnosis. Nevertheless, each of those blue boxes cause a disruption to an individual's personal, family, occupational life, economic well-being, and of course, there's a risk of suicidal behavior. So our research has been focusing, if it's not in this slide set, it's the next, is working on treatments that work within hours instead of weeks. That's, for example, rapid-acting antidepressants or ketamine or derivatives of that. Because what we think and theorize is, if each of those episodes, you might know, a major depressive episode can last 9 months without treatment. What we do with treatment or antidepressants, for example, is shift it so that it doesn't last as long. It may last 6 weeks, 8 weeks, 3 months. That's shorter than 9 months. Now, the problem is that it takes a long time to get better. And so what we have been arguing, if you can get better in hours or weeks each episode, and you do it for each episode, you might be able to decrease the amount of time you spend in depression. That's what we call cumulative probability of having depression. So about half of the life of an individual with bipolar disorder, they spend having symptoms of bipolar disorder. 1/3 of the time it's depression. And you can see all the blue boxes there. 1/3 of the time is spent in depression. And those who suffer from depression, bipolar disorder, are concerned a lot more about the depression. Family members, unfortunately, focus more on the manias because that's what causes issues and trouble. So you can see here to the bottom of the graph is a pie chart, and you can see the number of comorbid conditions, other medical or psychiatric conditions, 2/3 or more. And we already talked that affects outcome and important to treat. Okay, and this is the slide that I already mentioned. The time you spent in illness, you spent about half of the time with symptoms, 1/3 you spend in depression. Now, to the bottom right, this represents what I called, these are dendrites and neurons. So what we know from our patients with mood disorders is that with time, because of insults, excess glutamate, or hypoglycemia, low blood sugar. This is not just basically on diet. Other things, probably not good health, not taking care of oneself, eating right, so on and so forth. We don't know. There are many insults that lead to inflammation, and that leads to a shriveling or shrinkage of the neurons in the brain. What we know is that these are in the middle, it's in the cartoon to the right, is these, it looks like a tree in spring. So when it's healthy, you have branches, you have leaves, but with the shriveling over time, that's what happens in the central nervous system of patients with recurrent mood disorders. Starts looking like a tree in winter, deprived of branches and leaves. And so that you need not only the neurotransmitter, but you need what we call neurotrophic factors and other things very important. So what we call the miracle growth, miracle growth for your garden, theoretically the leaves and the branches increase. There are these products within the brain called BDNF, brain-derived neurotrophic factors, that are very important to the health of neurons and important in the communication of signals in the brain. And so it's not just medicines that regulate that, but we call plasticity enhancers, those that enhance the plasticity in the brain, how one neuron talks to another neuron. Okay, and this is a magnified cartoon towards the left are those little circuits, the spines and the circuits. That is a synapse, one neuron talking to another in the circuits, and that looks healthy on the left, the non-mood disorder. But you can see what happens on the right is a decrease in the circuits, a decrease in spines. And there are many factors that are involved in that. We think it has to do with neurotrophic factors. We have to think if there's too much oxidative stress or inflammation in the brain, or mitochondria, which are the power packs of the cell. So these are the treatments that we are looking at for the future to maintain to maintain ourselves healthy. Okay. Okay, this is now an area that we have for many years. Most of our treatments have pursued the monoamines or neurotransmitters, serotonin, norepinephrine, and even dopamine. Very important. But in recent years, what has taken off is glutamate and GABA. Glutamate is an excitatory amino acid. It's one of the most abundant, and then GABA is the main inhibitory neurotransmitter in the brain. And so you know that GABA has been linked to seizures, epilepsy. That might be involved in bipolar disorder, autism as well. And you can see towards the left is what we are neurons. The top is what we call presynaptic neuron. The bottom is the postsynaptic neuron. And towards the right and left of that figure is glia. These are other types of cell. And you can see in the bottom is the NMDA receptor. That's a very important protein in the brain where ketamine and other rapid-acting antidepressants work. And one right next to it is an AMPA receptor. It's another glutamate receptor. And so what is known is there's this cycle of glutamate. It's synthesized, and then it hits the neurotransmitter, propagates the electrical chemical signal downstream, and it sets the machinery in play. And so it's believed to a certain degree that this stress I mentioned, stress, leads to a reduction in a number of the receptors, a shriveling and atrophy. And so the chemical signal doesn't work as well, no matter how much neurotransmitter you say. So that's what I meant by plasticity enhancers, that they give treatments that enhance those proteins and receptors in the brain. Towards the right are what we call is post-mortem studies of individuals who've had mood disorders or suicide, and you can see problems with these receptors, NMDA and AMPA, just to show you that it's very important. There's some evidence that some of our ongoing treatments already regulate glutamate, and lithium has some effects on that. Valproate and lamotrigine or lamictal does that, and so that's a possibility why these treatments might be useful. They may not have as much of an impact as we should, because it's not just affecting one protein, but this whole machinery I mentioned. There's another treatment in the bottom, Riluzole or Rilutec, that's used for Lou Gehrig's disease or amyotrophic lateral sclerosis, that does regulate glutamate. And so there are different. Riluzole is also being looked at again in a different form. So this slide argues the need for improved treatments. I already mentioned some of that. We see very low remission rates. So if I give an antidepressant, it's estimated that it takes about 2 antidepressant trials for half of our patients to achieve remission. Remission means that you're significantly better, few symptoms or no symptoms. So that translates to close to 6 months. 6 months for half of our patients to achieve remission. That's very slow. Okay. So that's the lag of onset of antidepressant effects, and I would argue the lag of onset of anti-suicidal ideation effects. So during this time, we tell our patients, hang in there, you're going to do well, which is true, maybe, but we don't know who will do better. And many of our patients are suffering. They can't work, they can't take care of their families, their job, and there's risk of suicidal behavior. So if you look at the bottom, there's euthymia in yellow, and then depression. And I said it lasts about 9 months without treatment. So if I start treatment with Prozac, Zoloft, bupropion, or standard antidepressant, it takes about 10 to 14 weeks to achieve remission. And we've been arguing that this is what we have helps individuals, but it's unacceptable. We can do better. And we know now, and our work has largely focused on antidepressant effects in hours or days. And so if I already talk to you, every time you have a major depressive episode, you can shorten that. You will spend less time in depression throughout your lifetime. And so this is now a reality. We have ketamine. It's a prototype, but it has its issues we'll talk about in a minute. But we can develop better forms of ketamine that work in hours. And that's our goal. And also address suicide. So this is the glutamate system, and most of the glutamate in those white dots are stored. They go to the vesicles. You can see those little dots moving. I hope you can see it. Then it's released into the synapse, the space between the two neurons. And what happens is eventually it increases, activates the NMDA receptor, that key protein I talked about for glutamate. And then you can also regulate glutamate by going to this other protein. It's a EAT1, excitatory amino acid transporter. That's the thermostat. So if it's too hot or too cold, you can regulate it. And we can do that with certain treatments. You can also do this with another type of protein, mGluR2. Not that you're interested in these names, but the point is these are targets that we can begin to regulate glutamate. And why is that important? Well, an NMDA, because that leads to BDNF, brain-derived neurotrophic factor. That's the miracle growth factor I talked to you. And this is very important for learning and memory. So these are normal physiological processes for learning and memory. And so that we know is associated with the increase in spines and circuits, which have been shrivelled because of depression. So with these new generation treatments, not only do we regulate the neurotransmitter, but we increase the spines and the circuits to a healthy manner. As I mentioned, involved in learning and memory, and you can go from the non-depressed state, from the depressed state to the non-depressed state, back and forth. Okay. Now this is, I'm showing this figure, but you might say, I'm not interested in this figure because it has things I don't understand, many things I don't understand as well, but these are the targets that we and others are looking for to regulate glutamate. And so from the point of view of myself and our patients, this is encouraging because it gives us some direction and that there's going to be novel treatments down the road. We can talk more about that. Now, this is one example of ketamine. It's a prototype, but it's already on the market now. And this is something you may already have had a speaker who's already talked about ketamine, I presume, right, by now? No? Some point, okay. So this ketamine, if you remember that protein, NMDA, this is magnified, and it has a little channel where you have calcium go through it. It's an electrolyte, and it's important because that activates all the proteins important to increasing that BDNF. Okay. Now, what happens is that ketamine binds within this site, right in the middle of the channel. That's the site that's involved with the drug angel dust or PCP. And yes, go ahead.
Question.
Yes.
Is it true that ketamine can actually induce mania for people that don't only have unipolar depression?
So that's a very good question. I don't know if I have a slide, but the answer is it's a difficult question. It doesn't happen. It's not a very common occurrence. In fact, I think I might have a slide or two. We have given ketamine in our patients with bipolar depression. And just so you know, our patients who come to the research unit have been on an average of 5 medications. They come to the unit, they stay with us 2 to 6 months, depends. We take them off almost all their medications and leave them just on lithium or Depakote. And we give ketamine, and it shows a rapid antidepressant response in about half of our patients. And when you look at the changes in mania scores, just with one treatment, with either lithium or Depakote, people who are taking 5, we find that the increases in manic scores are very low, even less than unipolar depression, if you don't have any bipolar disorder. So the issue why we might not find very high rates of mania switches is because you're taking a mood stabilizer And second is we give pulse treatment. So we're not giving ketamine every day. We give ketamine 2 times a week. And why you might have switches into mania with antidepressants is because you're taking it every day, right? But if you don't take it every day, the antidepressant, it might not work because it takes a while for those changes in the circuits that I mentioned in the proteins to happen. With ketamine, those changes in proteins happen with just one infusion. So that might explain why there are lower switches rate. But to be fair is there haven't been really a study comparing switch rates of one versus the other. But in our studies, we don't see that in what's been reported. You may find a case report of somebody switching here or there, but so that's a good question. So it binds to the PCP site, and when it does, it shuts the channel down temporarily. And that's why people have what we call dissociation, out-of-body experience, that only lasts about 40 to 80 minutes during the infusion, and then goes away. And for the most part is tolerable. But you might have increases of blood pressure and pulse with ketamine. So our goal is to, in the beginning, was to see if we can come up with a new treatment. And if so, we can re-engineer the treatment to see if we can come up with something better without the side effects, right? Because first of all, you want to see if it works or not. Now, we know when you give ketamine, half of the people respond in a few hours or a day, which takes 6 to 8 weeks with a standard antidepressant. So you might say, oh, that's interesting, very important. Now we can figure out how to come up with treatments that don't have those side effects. Okay. This is to show you with the calcium. When it's blocked, it produces those psychological symptoms I mentioned, dissociative, and increases in blood pressure. Okay, up. Now this is the studies we have been doing at the NIMH intramural unit here, where you look towards the left is the depression scale, that's the Hamilton Depression Scale. And to the bottom, you look at the time in minutes and days. Most of the studies you see changes in scores in weeks. Here, we were measuring within hours. And in the green line is ketamine, and the red is the control condition. And what you find is with one infusion in our patients who had failed on average 6 antidepressants, a third had previous suicide attempts. A third had also failed ECT, electroconvulsive therapy, which is an effective form of treatment. They had a response within a few hours, with one administration lasting a week. But during the first 40 minutes to 80 minutes, you do have the dissociative side effects and the changes in blood pressure. We showed it in depression, bipolar depression, suicidal ideation is another. We found that suicidal thinking improves very rapidly. This is intravenous, a vein. And towards the bottom right is in pleasure or anhedonia. I talked about that. We find improvement within hours, lasting about 2 weeks. Now, without the treatment, it comes back to baseline. And so what people have been doing, and we have developed with others, is the intranasal form of ketamine called it's Spravato or S-ketamine. There's the intravenous, and which is off-label, and Spravato is FDA approved, and that is FDA approved for treatment-resistant depression and for adults with major depression and suicidal ideation. Okay, let's see. This is our 2 studies in bipolar depression. We were able to replicate. And what is interesting, it seems to have what we call broad therapeutic effects. Not only does depression improve, but the symptoms of anhedonia, suicidal thinking, anxiety symptoms seems to improve, PTSD symptoms in some of our patients, and are the main symptoms. Now, I am not saying everybody responds. No, about half of the people respond, and then they receive ongoing treatment with ketamine. This is to show you that we have been busy over the years looking at other forms of ketamine that would not have the side effects, and they're listed here. There's memantine, which is for Alzheimer's disease, or Namenda, and there's a few other drugs that we have tested, but none of them, unfortunately, have are like ketamine. There's also nitrous oxide or laughing gas. Many of you may have experienced being exposed to nitrous oxide, dentist office, or for procedures. And it seems to induce a rapid onset, but nothing like so far. This is to show you the research we do is with all these biomarkers. We're looking in all our patients, polysomnography of sleep studies, MRS that measures neurochemicals in the brain, such as glutamate levels or GABA levels that I talked about. We look at PET imaging that measures the receptors in the brain. MEG, we're doing quite a bit about that, looks at the electrical activity in the brain. It's like a fancy EEG. We're looking at functional imaging, that's fMRI, and also structural MRI. All this in the context of before, during treatment, and after treatment to try to figure out what is leading to the response or non-response, and coming up with better clues on biology, develop better treatments. So I'm not sure I want to get into this because a little bit more, too much detail here. Okay, let me switch now. That's okay, Alvin. I want to go to the other slides. Okay,
The thing I know to do.
can everybody see that? Okay, so I'm going to go a little bit into some new data. Some of it I may have covered, but I wanted to present this as well. Okay, so let's talk a little bit about epidemiology, meaning how common it is, depression and suicide, and bipolar disorder. You may know or not that suicide, there's about, sorry.
Safer, let me ask people online, are these new slides now
Oh, sorry.
visible?
Can you see the new slides online? Anybody?
This one says suicide rates in the United States.
We cannot.
Oh,
Okay.
you cannot. Right, very.
So what I know to do
How do we do
would
this?
be to stop share,
Stop share.
like the red thing at the top.
Oh, share.
You see where it says the red?
The red. Where is it? Oh,
Oops. Did you get that?
okay, and then go back to the slide.
Then go back to Zoom
Zoom. Okay.
and say share screen again,
Screen.
and this time click on the other presentation.
Got it. So share. All right, can anybody see there? No, we can't see here, right? Where is it? Where did it go?
Anyone understand this? What's going on?
All right, so let's start.
Using presentation mode.
What is
Say that again?
I said try using presentation mode.
presentation mode here?
Where's that?
Can you see that?
I think we have it here now. Can you see it?
Yes, we can see it now.
You see suicide rates? That's the title.
Success.
Great, thank you. Sorry, I apologize. Sometimes it's easier to use machines and imaging than it is to use slides, at least for me. All right, suicide rates. So it's estimated there are about 47,000, 48,000 suicides per year in the United States. So worldwide it is, anybody know? 800 to 900,000. Could be a million. And that's about one suicide every 11 minutes, unfortunately. So if you can imagine the length of my talk, how many suicides there have been in the United States, that's kind of sad. Towards the right, you see that 12 million have thought about suicide, 3.5 million have made a plan, and about 1.4 million do attempt suicide. So please, if you have a friend or a loved one, reach out. You can see in the middle, it's 800-273-TALK. And what has happened pre-pandemic, there was a steady increase in suicide rates per year, and I was quite worried that we were not able to bend the curve. And so in the last couple of years, what we see is that it has declined by 2.1%. And there are many explanations for that. But during the pandemic, actually, many individuals who suffered from mental disorders were actually feeling relieved that they didn't have to go out and work and be stressed. So that may have be one factor. We don't know for sure. So everybody knows about the major depressive disorder. I'm not going to go over the criteria, except we talked about apathy, loss of energy, one of the key symptoms. And in the middle, you see changes in appetite, in sleep, activity levels, fatigue, guilt, worthlessness, and suicidal ideations. And as I mentioned, there are hundreds of ways of meeting criteria for depression. Now, this is a little bit more elaborate that I talked about, that is a systemic illness. I already covered a few, but towards the top left, there are changes in the immune system. We see changes in what we call cytokines or important proteins that's involved in immune function called IL-1, it's IL-6, TNF-alpha. I talked about the cardiovascular system, the gastrointestinal system I mentioned as well. I talked in the bottom, osteopenia bone. And towards the right are the brain measures we're looking at. And we do know in depression, there are problems with sleep, where you find that there's changes in certain parts or architecture components of the sleep pattern. All these things that I mentioned, we're looking at the effects of ketamine. Because we're interested not only, of course, in if it improves mood and suicidal thinking and anhedonia, but what does it do to the rest of the body? And so that will give us clues of potentially other medicines we could develop to help these other conditions. Right? Now, this is what I mentioned earlier. We focus a lot on the depressive episodes. We already talked about how much time goes by between a major depressive episode and a hypomania. But a lot of times, as I mentioned, you have these sub-syndromes, not enough to meet criteria major depressive episode, or a manic episode that your family member or friend would call the doctor. But you have these fluctuations in mood. Very important to address that. And it not only for the mood side, but I mentioned if you have symptoms of some other disorder that does not meet symptoms, that does not meet the disorder criteria, panic, obsessive compulsive symptoms, you should address it as well. Okay, this is how common depression is. We look towards the left, you find that it's much more common, we know, in females and males, 10% versus 6%. Average is about 8%. Towards the middle, we find towards the middle, yes, the age group that is highest between 18 and 24 and starts going down at between 26 and 40s. And then towards the right, we find that it's more common in certain groups, not Caucasians or whites. In Hispanics, it's much lower than others, but we find those with mixed ethnicity races have higher rates. Now, what is surprising is, as well as the adolescents, and you could see the numbers in our adolescents, it's about 20% when it was about 8%. So it seems, and there's some argument that there might be a cohort effect. That means that every decade, the years go by, we see it starting earlier in family members. And there's some controversy on that, but you can see 20% rates in 12 to 17-year-old. And this is not to say if you have children, you're panicking, if you have, bipolar depression and you run to the doctor, hey, can you give them an antidepressant? No, but something that should be looked at and observed. And of course, the rates are actually 2 to 3 times higher in females, adolescent females than adult females. And then towards the right, we can see that depression is much higher in Hispanics and in whites than compared to other groups. Okay, this is about that there's about 9 million individuals who have medicated treated major depressive disorder, unipolar depression. About a third, that's 2 to 3 million, have what we call treatment-resistant depression. I'll talk about what that means. 8 million have bipolar disorder. When I say that, it's not bipolar 1 only, it's bipolar 2 in all the shades. There are shades between of severity and bipolar disorder. When you look at all that, it's about 8 million individuals. what is treatment-resistant depression? A concept that has been introduced is difficult to treat depression because treatment-resistant depression only refers to mostly medications and do you have a response or non-response rate. Difficult to treat depression includes other things such as quality of life, function, those, and so there's been a movement that probably that more reflects what our patients want and need. The concept of treatment-resistant depression is mostly focused on unipolar depression rather than bipolar depression. The bipolar disorder experts and researchers have trouble agreeing what is treatment-resistant bipolar depression. I'll talk about that in a minute. It is TRD or treatment-resistant depression. It is pretty common, and rates suggest that anywhere between 30 as high as 45%, 46% have treatment-resistant depression. But some groups say that you fill only one antidepressant and you have treatment-resistant depression, but you know that's almost everybody. So what is the agreement is that it's 2 antidepressant failures not responding to that adequate dose and duration. What I mean adequate dose, you really go up as much as you can tolerate within the recommendation, and be given at least 6 to 8 weeks. Now, there are some of our patients who cannot tolerate at all higher doses or a long period of time. They go through treatment after treatment after treatment. So some have considered, well, if you cannot tolerate 3 in a row, that might be considered an adequate trial. If you look towards the right, it's a much for bipolar depression. What is treatment-resistant bipolar depression is much more stringent. You have to be in remission for 8 weeks, consecutive weeks, to adequate dose of at least 2 treatments. Could be lithium, Depakote, lamotrigine in combination. And towards the bottom right, bipolar experts have come up with this criteria called category called multi-therapy resistant bipolar depression. It's a fancy way of saying we're going to count not only antidepressants or drugs, we're going to count therapy and brain stimulation, which makes sense. Okay, now if you contact Alvin, I can send you the PDF files or of these slides, and you can send it out. But this is kind of one of our fellows, Crystal Croft, came up with different levels of treatment. There's stage 1, there's stage 2, and stage 3. Stage 1 are different types of antidepressants you can try. Stage 2 are what we call augmentation. You add something, or you combine something, or you switch another treatment. And then the third is ECT or MAO inhibitors, and then the fourth are experimental treatment. So these are the 3 groupings. You try 1, 2, 3, 4 drugs. It's not unusual for our patients, and many of you know someone who have been 20, 30 antidepressants. Not unusual. You could try neurostimulation, or you can try some experimental treatment. Okay, and he added, it's joking, but it's true. It's a long time, to get through these trials. So there are currently no clear algorithms for bipolar disorder. There are different guidelines, and different groups say you should try different things. These are the different types of treatment. We have the mood stabilizers, which are focused on the course of the illness rather than the episode so much. Then you have the antidepressants, 2 schools of thought. Antidepressants are no good, stay away from antidepressants, is one group. Focus on mood stabilizer. Others say you can use antidepressants with mood stabilizers and then remove it once the episode is gone. In reality, treatment is very personal, individualized. Some things work, some things don't work, and it's hard to say that one approach works for everybody. Second generation antipsychotic drugs are used more and more and more. They're here: quetiapine, olanzapine, fluoxetine, lurasidone, aripiprazole, cariprazine, and then other novel. And so most of the time, the treatment is selected by side effects, what our patients want to avoid or take advantage of. When I say take advantage is if you're not sleeping, something sedating at night. If you're not eating, something that increases your appetite. So the treatment is like that. And it's important to keep in mind for bipolar disorder, it's much more complex because what might work for the acute episode might be different from the maintenance treatment. Unfortunately, what works for acute does not necessarily translate into maintenance treatment. Could, but not all the cases. All right, how to research treatment-resistant depression. So this is a schematic of why our treatments one approach on the future and how we should be thinking of coming up with better treatments. So you see that when we use these criteria DSM towards the left, you see major depressive disorder, and you see each person with a different color, how they group up is different from mild depression or dysthymia, that means chronic depression. And then in the bottom, you have bipolar depression, right? But what happens is that, as I mentioned, the symptoms do not map onto the biology. We've talked about that. So that's why it's been hard to come up with new treatments. So what are the new approaches? So some said, let's get rid of these diagnoses in general. This is for research purposes. And what you do is you start getting information, exactly what I mentioned to you, sleep studies, neuroimaging, functional, PET imaging, and then you let the results of these tests stratify our patients. So the strategy would be, if I gave you in the middle group an anti-inflammatory agent, right? Some people are studying like Coxibid for depression, then for the anti-inflammatory, it's not going to work maybe. Why? Well, because you're diluting the effect across all individuals. Not everybody has an inflammation type of depression. So towards the right, what would happen is if you use these strategies by biotyping an individual based on biology, you might identify those individuals who have more of an inflammation type of depression, and thus that anti-inflammatory agent might work. That's the theory behind that. We're not there yet, but it's an intriguing approach. This is not to say that you should go running out and try anti-inflammatory agents. All right. I didn't put these slides together, but they took a picture of me. I don't know why. These are my fellows. This is just so you know, this is experimental therapeutics branch. And this is our research unit, 7 Southeast at the clinical center. And what we are doing is a multimodal approach. The first level, we're looking at cellular, molecular. These are in our patients. All this we're doing in our patients. Circuits and systems. And then in the bottom, level 3, human clinical trials to come up with those subgroups I mentioned to identify who might be more likely to respond to a certain treatment. So towards the left, we come up with a target. That's the glutamate system I mentioned. Towards the middle panel, we do proof of concept studies with novel therapeutic agent versus a control condition, could be placebo on our inpatient unit or outpatient. And then towards the right leads to improved treatment. And you might say, well, this doesn't work well. We were successful in getting ketamine to the market. And ketamine is quite a radically different treatment. Yes, it has its side effects, its limitation, but we can work from there to develop into something better. And we have a few ideas. So this is a little bit more an example of how we think ketamine might work. Towards the bottom is you see the neuron, and these are the dendrite, the branches. And you might find a little tiny, on top of that, the bottom, you might find this inset where you have spines. One spine communicates with another spine, and then you have synapses and circuits, right? And so what is known is that there might be stress-sensitive spines, those that's in red. So when there's stress, they disappear. And stress-resistant is in green. And then what happens is you go from baseline to a stress condition in the middle. You see the number of those little spines decrease. With a treatment like ketamine or next generation plasticity enhancers, they don't create new spines, neurogenesis, right, new neurons, but they restore those red sensitive spines. So that's what the treatments are looking at. This is to show you on the right. An earlier study in 1997 showed that there was a decrease in the brain volume in the subgenual prefrontal cortex, which was like, wow, we found a lesion in mood disorder patients. or something going on in the brain. And you can see the volume of that region, PFC, was lower in bipolar disorder and unipolar compared to control condition. Not only was it structure, but towards the left is functional imaging. You see that there's a decrease in the metabolism in the subgenuine anterior cingulate cortex. That is the area where some of the antidepressants work, and also deep brain stimulation works. This is the earlier study. I don't know if I showed you this one. Did I show you this one? No. So this was the study where we used one of our earlier studies. I didn't talk much in detail, but this is depression score higher, and we find within 1 hour with 1 infusion ketamine, rapid response. And you can see here towards the right are monoaminergic-based antidepressants, Prozac, Zoloft, Wellbutrin. You get about a 62% response, 6 to 8 weeks. With ketamine 1 infusion in individuals who failed 6 antidepressants, you get it within a few hours. So something very important, but the effect peaks day 1 and starts going down by 7 days. But if you give it 2 times a week, it can maintain remission. This is to show you that there's about maybe 4 groups of compounds that are supposedly working rapidly. That's our focus. We talked about ketamine, nitrous oxide. Then the second group is the neurosteroids. One is brexanolone. That's for postpartum depression, seems to work fairly rapid. There's an oral form of brexanolone, that's Sage 217. Then there's the opioid drugs that are being looked at. And then in the bottom are the serotonergic hallucinogens, psilocybin. You may have heard that MDMA for postpartum depression. The experts did not recommend approval to the FDA. The FDA is going to consider that. That was for PTSD. And this is to show you that all these treatments that work rapidly, if you look at the top, there's the receptors. For example, opioids would work on the opioid receptors. Ketamine or glutamate would work on NDA. And then the psychedelic drugs, 5-HT8 works on the red receptor in the top. Okay, but as you go down to the middle or downstream, they converge. Most of them are involved in the neurotrophic factors anyway. They work on the spines that I mentioned earlier. So the converging glutamate seems to be a very important system for this. So we may be able to come up with different treatments that start somewhere else, but they all come to the common targets downstream. Okay, we're going to skip that. And just to talk, just to summarize a few of our studies, and then I'll wrap up. So one is called the neurobiology of suicide. We're trying to figure out with different modalities what goes on in suicide. So you can see the suicide risk from high to low in red, and there's a threshold. And what we have identified is several groups. There's the active suicidal crisis. You cross that threshold. In the middle, you find that our patients have a psychiatric diagnosis, but very rarely do they even think or have suicide attempt. And then towards the bottom, individual with suicide risk, low suicide risk. And we have healthy individuals in that group. Why would you say healthy individuals? Well, there's some healthy individual with no psychiatric disorder. When they're exposed to losing their house or some severe trauma, they attempt suicide. So you can never say anybody does not have suicide risk. And so we're considering different groups. And what we do is all the technologies I mentioned, the structural imaging, and we assess people who have suicidal ideation, who come to our unit within 72 hours. We do all this workup and send them home. Now, others don't come from the other risk groups. They're welcome to participate in these studies. So it's a multimodal that we think will provide important clues. Then we have brain stimulation. We are looking at new forms of ECT that some of them do not induce the seizures. We're trying to study, is seizure necessary for the antidepressant effects, because it does cause cognitive side effects. And so these are the studies by our unit, NNU, led by Dr. Holly Lisenby. And these are some studies. We do TMS with psychotherapy to try to enhance the plasticity I talked about. In the bottom is a test study that looks at, I don't know if people have interest, I can send you the slides, or the PDF, that looks at other devices of ECT. This is a study that we're looking at mechanism. So our patients get ketamine, and we pre-treat with a drug that blocks AMPA receptors. That's the key protein. We want to know if AMPA is important. And if so, then your antidepressant effect should be diminished. And why is that important? Well, if we can figure that out, then we can develop specific AMPA drugs. This is the design. And then to wrap up, we're looking at a new form of ketamine called hydroxynorketamine that we have been developing since 2016 at NIH. In essence, what it is that when I give ketamine, I think I have it in the next slide. It's probably hard to see, but when you inject ketamine in a rodent or you take it in humans intravenously, ketamine has 24 metabolites within minutes. So how do we know it's ketamine, the main thing causing the antidepressant effect? It could be one of the 24 metabolites. Maybe some of them involved in efficacy, some of them are involved in side effects. So without getting into much detail, we were able to figure out in animal studies that there's one candidate drug called 2R6R hydroxynorketamine HNK, what I call the son of ketamine, does not block the NMDA receptor, which is responsible for the dissociative side effects in the risk for abuse. It produces it activates the AMPA receptor that I talked about. That's important, and it doesn't produce the side effects of ketamine. So we have done phase 1 in healthy volunteer studies, and the study should start this week or next week, where we'll give in treatment-resistant depression 2 times a week for several weeks, compared to a controlled condition on an inpatient unit. So that's hydroxynorketamine, and that's an example of a new drug that we are hoping would work. And this is a study. Wow. Okay. So to wrap up, I think there is, if you have, if you want some information, I could send it as a handout for those with mild depression or severe depression helpline. And I know all of you probably are connected already, but there's quite a bit of help. And I will provide information on how to contact us if you have interest in one of our studies or a referral or consultation. So I'm going to stop there and thank you for your attention. So I know we may have gone over, or maybe not. Oh, not yet. If you have time for a question or comment.
Are there questions?
Before we wrap up.
We'll start in the auditorium.
Yes.
On the opioids, when I hear that, I think of fentanyl and the dangerous opioids. Have you figured out a way to make them without having them be so dangerous?
Yes. Can everybody hear online that question?
I
Okay, the
doubt
question,
it.
I'm going to repeat it,
Probably
is
don't.
with the opioid, which is one of the classes being looked at as a new antidepressant potential with rapid acting antidepressant, you have fentanyl and other opioid type drugs. Have we figured out a way of diminishing the misuse risk or abuse potential of it, because there are already concerns and issues with it? We are doing quite a bit of studies on that, where ketamine, for example, I'm talking about ketamine, has a structure where it calls 2 enantiomers. They're the chemical structure has an R and S. And so when you break up ketamine, the S enantiomer seems to be the greatest risk of abuse potential, the R less so. We've done the same with esmethadone, one of the types of opioid drugs, where you have the R and the S, and one seems to have a greater risk of abuse or not. Still, it seems that the other does have a risk of abuse, but less so. And we have looked at that VTA ventral tegmental area, the reward circuit, and there seems to be a protein that we think might be important to diminishing the abuse effects. But it's research in progress. We don't have the secret ingredient yet that would minimize the risk of opioid. But that's a very good question, because if we can figure that out, you can use it for pain. Hydroxynorketamine, for example, we're going to be using for pain studies as well. We have pain studies wrapped up. But if we can figure that, you can use it for pain, and you can use it for other conditions with a low risk.
Other questions? in-house. Let's turn to questions online. Are there questions? Are people able to mute and ask them? And I also ask if there's anything in chat. Stephanie, are you there?
There's a chat here. Here it is.
Yeah, you can click on chat.
Okay, hello. Okay. What other rapid acting drugs besides ketamine did doctor reference? Okay, so maybe this was earlier. I talked about generally 4 classes. The first is the glutamatergic, which is ketamine, nitrous oxide. Then the second, and there's others. One of them is Auvelity, that's now on the market. That is dextromethorphan or cough syrup with bupropion or Wellbutrin, but it's not rapid acting, and it's approved for major depression, not for treatment-resistant depression so far. Then we have the opioid drugs. We talked about that. Some of them didn't pan out. They're still being studied and considered by the FDA. And then we have brexanolone. I mentioned the neurosteroids that's used for postpartum depression intravenously, and then the pill. But as for postpartum depression, not approved for major depressive disorder. Actually, the FDA didn't accept it for major depression. And then we have the psychedelic drugs, which you probably have heard of quite a bit about. Those affect the 5-HT2A receptor. There's several there, but they're still early in development. And there are others, but I think those are the most common groups. Then, let's see. Hi, Patricia. Okay, so somebody, yes, we will be given the handouts. How often are people misdiagnosed with treatment-resistant depression, trying different antidepressants with no relief to the depression when they actually have bipolar? It's a very good question, and I unfortunately quite often. In fact, my predecessor from the inpatient unit, Dr. Post, I think did a study where I think of those referred as treatment-resistant depression, only 1/3 did not have only 1/3 had treatment-resistant depression, and we found comparable numbers. You find, unfortunately, many of our patients who are referred to us have gone through many treatments, very short. And understandably, because people want to take care of the kids and they want a quick fix and they want to get back to their job. But when they stay on our research unit and you spend time with them, educating and go through the trials, many get better with a good trial, but you have to hang in there. Now, I understand that that's not easy in the real world, and that's why we're looking at, rapid antidepressants. It's not a quick fix, but in some ways it is a quick fix, hopefully. So it's quite common. And bipolar depression, yes, as I mentioned, sometimes many years go by until the correct diagnosis is made. And that's unfortunate. And so later on in life, when you have the hypomania, mania, you might be able to find out.
Question here?
Have you looked at VNS?
Vagal nerve, yes.
Treatment?
We are not looking at ourselves. Our neurostimulation program is looking at not vagal nerve stimulation. If you would, a place that's doing it is Scott Aronson at Shepherd Pratt has a very large program. We're focusing in vagal nerve stimulation, works in people who failed 4 to 6 antidepressants. But it seems to take quite a bit of, you get about 19% response. You would say that's not a lot, but that's after months and months and months, even a year. For those who get better, of course, they say this is great, but we're looking at magnetic seizure therapy. That's another type of ECT. We're looking at tests and yet another device. And we're going to be looking at a study we plan hopefully next year or so. Saint, that's given TMS in 5 days as opposed to 1 month, compared to ketamine, to see which one works better or they're equivalent. And I will the help number at NIMH. Does anybody have it? Because I would have to go back to the slide and I'm not sure to figure it out. We'll give it. I'll send it to you.
Yeah. Let me say we will aim.
Oh, here it is. 800.
Oh, here it is. Stephanie sent it. 800-273-TALK.
Yes, please hand it out, and if you want something specific from our research program, contact us, but that's for immediate help. Okay. Yes. Ask.
Anyone else online on Zoom? If so, if not, what I wanted to say was we will endeavor to get this presentation up on the website. There are others already on the website. Stephanie, if you'll stay on the line, make sure I do what's needed to get it, but I'm gonna first, when we call it a night, go back and set out the slight refreshments I brought, which I got in too late to set up so people here can have them. But in the next week or so, these should be up, and whatever Dr. Zarate wants to send us as well, we'll see it's posted on the website in connection with that, so that people will be able to see the presentations and everything else, the literature Dr. Zarate wants to offer to us. Thank you. If that's okay. Okay, any other comments online or in-house before we call it a conclusion?
Thank you.
Thank you.
And let me thank Dr. Zarate. He's been an excellent presentation, and I'm pleased we're in an age when we can do it this way.
All right, very good. Thank you all. Signing out.